a pleasure to be here, and as Steve said, I am the first director of FDA's new Center for Tobacco Products, and this was set up now a little more than 3 years ago after Congress finally gave FDA regulatory authority over tobacco products. I can't, as Steve said, I am a public health guy, I'm a clinician, I can't talk about what FDA does in tobacco without framing it in the context of the public health impact of tobacco in this country. Tobacco use is the leading single preventable cause of disease and death in the United States. Every year, almost 500,000 people die directly related to tobacco use, and almost 9 million smokers have at least one serious illness due to their smoking. This institution and every other healthcare institution in this town and across the country is peppered by men and women who are suffering from tobacco-related diseases. We are talking a lot about federal expenditure these days and budgets, and tobacco has been attributed to almost $200 billion of annual lost productivity and medical costs. So if we want to make any improvements in budget in terms of health care, tobacco may be a place to make some progress. Very importantly, after decades of progress in terms of reduction of tobacco use among the population, that really has stalled out. And since about 2004, the smoking rates among adults has been consistent at about 20%. 1 in 5 adults smoke. More worrisome, though, is the fact that the decline in youth tobacco use also has slowed. So nearly, CDC tells us that nearly 20% of high school students report current cigarette use. That's 1 in 5 kids in high school, current cigarette use, and nearly 9% of high school kids report using smokeless products. Every day, almost 4,000 young people under the age of 18 smoke their first cigarette, and every day, almost 1,000 kids become daily smokers. More than 80% of established U.S. smokers adults say they started as teens, and about half of the new smokeless tobacco users are under the age of 18. And CDC recently has reported that 14% of high school students report current cigar use. So this is not just about cigarettes. Cigarettes may be the biggest bad performer today, but it's other tobacco products as well. I don't think I have to tell this audience about all the health effects and health consequences of cigarette smoking, but obviously the genesis of, I think, 17 or 18 different types of cancers, all kinds of cardiovascular complications, pulmonary complications, women's health, and then there's, of course, the health effects of secondhand smoke on both kids and adults. We in the healthcare professions are not in the ivory tower when it comes to tobacco use. Certainly many of our own faculty and friends have either currently use or have used tobacco products, and we have been part of the marketing of tobacco products in this country. And these are real ads from the 40s, 50s, and 60s featuring healthcare providers hawking tobacco. This is Surgeon General Luther Terry when he announced his iconic 1964 report, which was really a frame shift in our thinking about tobacco use in this country. No reasonable person should dispute that cigarette smoking is a serious health hazard. This really did shake the earth at that particular time because the use of tobacco products in our nation was so prevalent. And it's not only cigarettes. This is a very important message. It's other tobacco products too. Tobacco smoke contains many of the same toxins of cigarettes, and in some instances much more, and are actually higher in nicotine content than cigarettes. Smokeless tobacco also, we know, causes many diseases and cancers. This is a slide from the Centers for Disease Control that shows the decline in cigarette smoking among adults between 1965 and 2010. And you see there was this more rapid slope up until the mid to late 90s, and then it's been really leveling off since then. And if we blew this up to the last 10 years, it's pretty much of a plateau at about 20%. I take care of veterans. Many of you take care of veterans, and you need to know there continues to be an epidemic of tobacco use among our active duty service members and military veterans. Smoking in active duty U.S. military personnel ranges from the low is in the Air Force of 23% and the high in the Army of 38%. And Now that we have many more women who are defending our country, I'm sorry to say many of them also are using tobacco products as active service members and as in veterans. And CDC's Preventing Chronic Disease report just last year demonstrated that as many as 27% of our nation's veterans currently smoke. Again, I don't have to tell this crowd the important benefits of cessation of tobacco use. So I'm not going to go into details here. But the reality is that 70% of adult smokers in consistent surveys say they want to quit and make quit attempts every year. So why don't people quit? It's a no-brainer. It's the nicotine. Nicotine is one of the most addictive substances known to man. And from the great medical journal, the New York Times, this quote, and look at the date here, this is 1987. They were reporting on some studies. I think this was actually probably one of the Surgeon General's report that they were reporting on. But nicotine is harder to kick than heroin. Its hooks go so deep, involving complex psychological and physiological mechanisms that drive and maintain the smoking behavior. So as clinicians, the real issue here is the nicotine is the hook that keeps people exposing themselves to the toxicants of the tobacco product they're using repeatedly over and over. And that is then the pathologic equation of tobacco use. Nicotine itself, we know because we use it for tobacco use cessation and treating nicotine addiction. Nicotine itself is not, other than being addictive, is not actually that harmful. This is a fascinating slide from the 1988 Surgeon General's report that shows you the relapse rate over time of heroin, smoking, and alcohol. And you see really the complete overlap of relapse rate of heroin users and nicotine users, smokers, over about a year period. And so the relapsing nature of tobacco use and the addictiveness of nicotine is something that is much more powerful than many people had originally conceived. And so we as clinicians, thinking of nicotine addiction on a similar par with heroin addiction is something that is useful, I think, in the clinic. Obviously, treating tobacco dependence like hypertension, diabetes, and arthritis, tobacco use is a chronic relapsing condition that does require repeated treatment before long-term remission is achieved. So every attempt that a patient makes to quit is a successful attempt, even if that attempt lasts only several days or weeks. It gets them further down the road. Clinicians must consistently identify and document tobacco use status and treat every user seen in the healthcare setting. Dependence treatments are effective across a broad range of populations, and brief dependence treatment is effective, as well as individual, group, and telephone counseling. And effectiveness, of course, increases with treatment intensity. Now, another part of FDA, the Center for Drug Evaluation and Research, has approved 7 different types of smoking medicines to treat smoking cessation or nicotine dependence. So again, tobacco use is the leading preventable cause of disease and death in the United States. So what are our goals? Our goals are to prevent initiation of tobacco use, to encourage and support cessation. You, us, all in the healthcare enterprise have a big role there. And then, very importantly, to reduce harms of tobacco use. The last part is something I want to spend some time talking about. This is a picture of President Obama signing the Family Smoking Prevention and Tobacco Control Act. It was passed with very large bipartisan majorities by both houses of Congress and signed by the President June 22nd, 2009. This law, for the first time, granted FDA authority to regulate tobacco products intended for human consumption. And that's a queer kind of term, but it's a term in the law. And it distinguishes tobacco products intended for human consumption or personal use, recreational use, as opposed to tobacco products that are used to treat a medical condition like nicotine addiction. It gives FDA additional authorities over tobacco products intended for human consumption. This law recognized FDA as the primary federal regulatory authority with respect to the manufacture of tobacco products, the marketing, and the distribution of tobacco products. So for the first time, FDA now has authority over how these products are made, what's in them, how they're engineered, how they're sold, and how they're marketed and distributed around the country. The law gave FDA direct authority from the law over cigarettes, cigarette tobacco, roll your own tobacco, and smokeless tobacco. And it enables FDA to assert jurisdiction over other products such as cigars, pipe tobacco, hookah, e-cigarettes, and other novel products that are being developed. And FDA has announced our intent to assert jurisdiction over all products made or derived from tobacco. Now let me take just a minute and as practicing clinicians, let me just make sure you understand what the Food and Drug Administration is and what we do and how we do it. So there are 6 centers that make up the whole Food and Drug Administration. There's a Center for Drug Evaluation and Research, and they deal with medicines that treat people. Center for Biologics, they deal with vaccines, blood products. Center for Devices and Radiologic Health, pacemakers, x-ray machines, et cetera, all the devices that we use in diagnostics and in clinical medicine. There's a Center of Veterinary Medicine, a Center for Food Safety. Now there's a Center for Tobacco Products. Now, the Food, Drug, and Cosmetic Act allows us to do all of this stuff. The Food, Drug, and Cosmetic Act did not include tobacco products until the President signed that law in 2009. So what we do at FDA in all those centers, including the Center for Tobacco Products, is we use the best available science to regulate food, human and veterinary drugs, vaccines, biologic products, et cetera, and now tobacco. We help the public get accurate science-based information to protect and improve health. Now, the traditional FDA regulatory standard that you and I are used to in the clinic, that what we call the safe and effective standard, and that is that when I write that prescription for erythromycin, it's a licensed product because the company who makes it has proven to FDA that it's safe for human use and it has effectiveness for its intended use. Obviously, that standard doesn't work for tobacco. And so this law gave a new regulatory standard to FDA specific for tobacco that is based on a public health, population health regulatory standard. So for the first time, FDA has a new regulatory standard to use in its development of regulations for an industry. Now, tobacco control is not new to any of us in healthcare and public health, and we've always had the tools of prevention, of treatment access, of surveillance and education. Lately, we see great incentives in tax and price incentives, clean indoor air laws. Now, there's a new arrow in the quiver of tobacco control, and that is tobacco product regulation and what we can do to manipulate the product, how it's made, how it's marketed, how it's distributed. So FDA's public health goals for tobacco products are articulated here. And this is a distillation of the 225-page law that the President signed. And this is our articulation of the goals of that law. First, to prevent youth tobacco initiation. Second, to encourage adults who use tobacco to quit. Third, to reduce product harms and reduce product addictiveness. And fourth, to develop a science base and continue meaningful product regulation to reduce that toll of tobacco-related disease and death. Now, I've begun to talk about some of the authorities FDA has. Let me talk about some of the limitations. No federal law it goes one direction. It's always a balancing act. So this is part of the balancing. So this law gave FDA authorities, but also gave FDA some significant limitations. So FDA's authorities do not extend to setting tax rates for tobacco products. We in the Center for Tobacco Products don't regulate therapeutic products like nicotine gum and nicotine patches. That's our sister center, the Center for Drug Evaluation. We cannot set clean indoor air policies in this center. We do not regulate tobacco growing. We can change levels of nicotine and other products, other constituents of tobacco products, but the law specifically says we cannot take nicotine level to 0. And we cannot require the use of prescriptions in the purchase of tobacco products. So, as Steve said when he introduced me, this is the first new center that FDA has in 35 years. So, in the first 3 years of our life, our priorities has been, one, establishing the center. I was the first employee of the center September 2009. We now have about 425 employees as we're building this center. The law gave us many very aggressive statutory legal requirement deadlines. And we've been focusing on those because I don't want to violate the law. And then very importantly, and how I'll focus the rest of this talk, is on developing what I call the FDA tobacco product public health regulatory framework. This framework, this public health regulatory framework for tobacco, has 8 pillars to it. First, obviously, since this is the first time FDA has authority over these products, we have to understand these products. So that's the first pillar. Second is to control product changes that have an impact on public health and use our regulatory authorities to do that. Third, to prohibit false and misleading product claims that may state or imply a reduced risk of use of those products. Fourth, to decrease tobacco product harms. Fifth, to expand the science base for regulatory action and evaluation. Sixth, to restrict marketing and distribution to protect the public health. Seventh, to ensure compliance with FDA regulations. And then eighth, we have authority to educate the public about what we're doing. I'll take each one and talk briefly about them. So first, again, first time FDA has had this kind of authority, so we need to understand the regulated products. Very first is a requirement in the law that for the first time, tobacco manufacturers and distributors and importers have to register with the Food and Drug Administration. They have to say who they are, who owns them, who's their point of contact, and what products they sell in this country by brand and sub-brand. Second, they have to report the ingredients of their products to the FDA. It is the first time that the tobacco industry has had to report the specific ingredients and constituents of their products to any government agency. I like to say, and I say this in more public talks, but cigarettes are likely the only mass-consumed product in this country for which consumers do not know what's in them. That day is over. They also have to report harmful and potentially harmful constituents of each of their products by brand and sub-brand. And a harmful or potentially harmful constituent is defined as those that cause or have the potential to cause direct harm, either toxicity or addictiveness, or indirect harm that might increase initiation or decrease cessation to both users and non-users. FDA has identified a list of 90 harmful or potentially harmful constituents in tobacco products, of which industry now has to report the level of each of these to FDA by brand and by sub-brand. And they are now under requirement to report the first 20 on the first 20 of these. And this is just a list of some of those toxic ingredients or constituents. And you can see these are bad performers. Number 2, control product changes that have an impact on public health. We know the tobacco industry manipulates and changes their products constantly to keep market share and to attract new consumers. So now pre-market review is required when they want to propose any changes in their product. And the law requires manufacturers to inform FDA of any changes of existing products before they make those changes. So this is a complex system. So every tobacco product that is currently out there now has a relationship with FDA. And so the Tobacco Control Act requires FDA, gives FDA the authority to establish what I think of as a ceiling of harm that was caused in the whole population of tobacco use as of February 2007. Now, it's a complex reason why that date was chosen, and we can talk about it later. But essentially, the harm caused by exposure of tobacco products to the entire United States population is fixed as of February 2007. And any changes that a company wants to make to a specific product, from that date forward, they have to submit that information to FDA, and it can get no worse than that. New products that are not substantially equivalent, that's what that acronym is, SE means substantially equivalent, can't be introduced into the market without FDA evaluating the science and determining that the marketing of that product would be appropriate for the protection of public health. What that means is essentially they can't propose more tobacco-associated nitrosamines or carbon monoxide exposure than was set February 2007. There are then 4 pathways for tobacco products to be available for marketing in this country today. First, there's a grandfathered clause there, and that is if your cousin owns a tobacco manufacturer and he has products that were on the market as of that date in 2007, and they haven't changed at all, no changes at all, they're grandfathered. We don't have anything to do with them. They can keep marketing their product. They have to prove that there's no changes. Also, if your cousin's tobacco manufacturing plant wants to produce a new product that wasn't on the market, pre-market review is required. FDA has published a guidance on what scientific information we would need to be submitted to us to allow that product to be marketed, and the science would have to demonstrate that it would be, quote, appropriate for the protection of public health. This is a phrase from the law. So they would have to submit scientific information that proved that there was no worse harm to the public and that it would be appropriate for the protection of public health. Then the third pathway is this thing that we call substantial equivalence. It's an alternative pathway to new product applications where the characteristics of a product are the same as one of those grandfathered products. And the change, any change that they might be proposing, does not raise a different question of public health. So let's say they propose that there would be a change, but they would have to prove in scientific information submitted to the FDA that there was no different questions of public health raised by the marketing of that product. Then there's an exemption to the process. Moving on, FDA now has the authority to prevent false and misleading claims that state or imply reduced risk. We may remember, those of us that are a little older, the attempt of low tar, low nicotine cigarettes. People were beginning to understand this stuff killed, and so the tobacco industry said, oh, let's reduce the amount of nicotine, let's reduce the amount of tar, let's market that to the public. And guess what? 85% of the public thought, it'll be better for me. It'll be less risky if I use those products. Here are some of the ads. Marlboro Lights. U.S. government reports Carlton is lowest, etc. This was real. This really galvanized the tobacco-using community when, in fact, there may be lower tar or lower nicotine, and it killed equally the same. It was a phenomenally successful marketing tactic that we in the health and public health community bought into. So a very important public health lesson here. Measure what, know what your goals are, and know that you're going to be able to get there. So these are just some ads on that. So in terms of preventing false and misleading claims, FDA now, under this new law, will allow reduced risk claims and descriptors such as light, low, or mild when they are scientifically supported and FDA issues an order. So FDA now has what we call a modified risk application guidance. Again, your cousin's tobacco company. Let's say you've got a chemist in that tobacco company that has really come up with a better mousetrap and figures out how to remove a lot of tobacco-associated nitrosamines from tobacco products. And it really would reduce that risk. Well, we've signaled what scientific information they would need to submit to FDA to prove it before we would allow them to market that with a claim of reduced risk. And again, the standard there, again, this is articulated in the law, is that the marketing of the product either will or is expected to reduce the risk of tobacco-related disease and benefit the population as a whole. The underlined part is from the law. So this is the standard now that FDA has if we ever allow a product on the market to be marketed with a claim of a reduced risk. The fourth pillar, and this is very important, is that we have the authority to decrease harms in tobacco products. And we have the concept in the law called tobacco product standards, and FDA can issue standards appropriate for the protection of public health, including making the regulated products, and today that's cigarettes, cigarette tobacco, and smokeless tobacco. We can issue standards that are appropriate for the public health and making products less harmful by manipulation of the nicotine level or addictiveness of the product, the amount of exposure in an individual product of specific harmful constituents. You saw some of the list of that before, but it also could be others as well as how the products are made or engineered. We're now learning how exquisitely engineered these products are. The amount of nicotine delivery is known by the tobacco industry by puff of a cigarette. And there are drug companies that would love to know what that technology is for inhalable drugs. The products standards that we set in FDA have to be based on good science. Now, Steve Finn and I might know that reducing nicotine is a great thing. We might, at a bar, decide what the best level would be, but that doesn't matter. FDA has to have an appropriate level of science saying this is a level of nicotine we might say reduces the addictiveness of a product to 98% of the population. We'd have to have the science and publish that science as a scientific base for what we do, as well as for any other tobacco product standards. Product standards will use that public health, population health regulatory standard, taking into account users and non-users, and that is not just tobacco consumers, but everybody else, and looking at the effects of any regulation on initiation or cessation of tobacco use. Fifth, and very important pillar, particularly since this is a new area of FDA's authorities, is to expand the science base for whatever regulatory action we do in FDA. We've already begun to establish relationships with sister federal agencies in the research community. We're supporting many grants and contracts in tobacco-related science. We've established and will soon fund a tobacco regulatory science Centers of Excellence program through the NIH, setting up centers around the country in academic centers like here to explore very important areas of science and toxicology, chemistry, behavioral medicine, addiction, et cetera, so that we get better and better science to support FDA's activities. We've established through the National Institute on Drug Abuse a nicotine research center to help us with that very crucial area. We've already launched a very exciting program called the Population Assessment Tobacco and Health Study. It's a prospective 60,000 person cohort study that will run, well, it's for right now for 5 years, but my intent is to run it for 20, 30, 40 years, that will follow tobacco use patterns in the United States. 60,000 tobacco users focus on different demographics, particularly youth, and we'll have biologic specimen repositories and track both tobacco use as well as diagnostics and disease incidents and other very important issues. We're working with the Centers for Disease Control and helping supplement the survey and epidemiologic research that CDC does, both in epidemiology as well as in the laboratories. This year, we project about $175 million of spending and sending from FDA to CDC and NIH, and that will likely increase. Other authorities we have is to reduce marketing, restrict marketing and distribution, particularly related to reduce youth initiation of tobacco products, because as I said before, 70–80% of people who started to use tobacco products did start as kids, and most people regret that. So there's already regulations and restrictions in place by FDA now that set new national standards to reduce youth attractiveness and access to tobacco products. Several of these standards, these restrictions are on this slide. There is no longer sales to people of regulated tobacco products, sales to people under the age of 18, breaking apart packs into loosies and selling individual cigarettes, no more use of tobacco brand name sponsorship of athletic events and musical and cultural events, no more giveaways of hats, t-shirts, gloves, purses, radios with tobacco brand name logos on them as marketing, and there's no more vending machine sales of tobacco products in anything other than an adult-only facility. Those restrictions are in place, and FDA is a regulatory agency. We have to enforce our regulations, and Steve has told you a little bit about my history in public health, and now I like to say I've always liked to talk about public health things, and now I'm a public health guy, and I'm a public health guy with a badge. So, so we do enforce these restrictions, and so there are we do undercover buy inspections around the country where we hire minors to go into retail establishments to attempt to purchase regulated tobacco products, and hopefully there's not a violation, but if there is, then there are sanctions. Inspectors also check all other FDA regulations around tobacco that are in place, some of which I just explained to you. When we enforce, we've got varying levels of enforcement capability. We can issue warning letters, we can issue fines, no tobacco sales orders if there's repeated violations, and even criminal penalties. As of a week ago, FDA had conducted already over 111,000 inspections in retail establishments around the country, and it issued 5,000 warning letters. The warning letters are violations, and we've already issued almost 400 civil money penalties or fines, and those are places that violated once and were found to violate twice or 3 times. So there's a lot of tobacco sales going on to kids in this country. Like our sister centers, we also have authorities to inspect manufacturers, and we're doing unannounced inspections of tobacco manufacturers in this country. And so that's required to happen every 2 years, and when those inspections go on, we inspect to determine compliance with provisions of FDA authorities that are already in place. We have authority to educate the public. We've already started doing that with education campaigns, and there's warnings also, health warnings on smokeless tobacco products. There's graphic health warnings required on cigarettes and cigarette advertising, and I'll show you a picture of those in just a second. That's under litigation right now, so there's a stay on FDA implementation of that requirement. And then we have the authority to and requirement to publish that list of harmful and potentially harmful ingredients and educate the public about what it means that there's arsenic in your cigarette or benzene in your cigarette, etc. And then we will have very vigorous paid media campaigns, like you recently saw the TIPS campaign from CDC on TV recently, and so we'll be doing things like that. This is just a picture of the 9 graphic health warnings, both the new text warnings as well as the photographs that FDA requires on every cigarette pack and in every cigarette ad to take up the top 50% of every cigarette pack in the country, front and back. That was put in place June of last year. We took bets at FDA how long it would take the tobacco industry to sue us, and it took them about 60 days, and they filed federal suit in multiple courts around the country. And currently, FDA, there's a stay on implementation of this while these suits are working their way through the federal court system. And at this point, the federal courts at the circuit level has ruled against FDA. So at this point, this is on hold while it's working its way through, and it has been announced that there'll be an appeal to the entire DC circuit, and then the results of that, we'll see what happens. And my own prediction is that this will end up at the Supreme Court sooner or later. So you've seen some of the authorities we have, and I want to close with just talking about the possible impact of FDA actions, and particularly related to you and the work that you do here in the clinical setting. So FDA has authority for reporting of those harmful and potentially harmful constituents by brand and sub-brand. So this is going to be the revelation of new and, I think, very interesting and powerful knowledge about tobacco products in this country. But by getting that reporting out there, and we have a requirement to educate the public about that, might that cause users to think that some products are safer than others? So let's say brand X has a certain amount of arsenic and brand Y has half of that. Well, maybe that's going to drive consumers to that other product thinking that it's actually really safer. We're not sure what that really means. Second, FDA authority is that we have pre-market review of new tobacco products, but could users think that products then have an FDA approval? I mean, we all think of FDA as this sort of good housekeeping stamp of approval. That may work for drugs and devices and foods. It does not work for tobacco. And so how do we articulate that FDA's role and involvement in this does not indicate all of a sudden these products are, quote, approved? Third, FDA has the authority to ban those misleading descriptors, light and low and mild, but we can allow modified risk claims when they're proven scientifically. But could tobacco consumers think safer products are actually safe? And how do we articulate that nuance in FDA's role and responsibility? Again, in terms of what we do in the clinic, particularly related to interest in quitting, FDA authority is we can set these tobacco product standards to be less toxic, less addictive. But again, could tobacco consumers think that safer products really mean safe, or those less harmful products, could availability of those actually increase the number of users? I've already talked about those authorities at the bottom of the page, so I won't again. So I think the implications for us in the clinic are that FDA actions now already, some that I've already talked about, but those that we'll be doing in the future, will have the potential to significantly decrease initiation of tobacco use, and we hope increase interest in quitting tobacco among tobacco consumers. So we as clinicians, though, have a critical role to play to catalyze and capitalize on FDA actions as they begin to happen. First, obviously asking each patient about their tobacco use. And just because my patient wasn't using tobacco last time I saw her doesn't mean she's not using it today. Second, to encourage those who already use tobacco products to stop and do that every time. I've got patients who, they've kept, every single time I see them every 4 months or 6 months. And, doc, I'm not ready to quit. No, doc, I'm not ready to quit. And then all of a sudden, my cousin just died of lung cancer. Help me out. So don't miss those opportunities. There are naturally occurring opportunities in almost every clinical interaction that we make, and we should take advantage of those. Link any current tobacco consumer to effective treatments, and there's a host of them. And then proactively encourage those who don't use tobacco products to not start. This is just a list of how to contact us at FDA for more information about what we do. There's one of the links here, actually, you can sign up for a weekly update from my center that will just come automatically to you. We do this weekly thing, we post it. It's actually how I find out a lot about what's going on in my own center, so it's relatively good. Let me close with doing a bit of a history and visioning. So down in the left-hand corner is, again, Dr. Luther Terry, Surgeon General of the United States, at the press conference releasing his iconic report that really signaled to all of us in the medical and public health world the dangers of tobacco use. And again, 1964, there's the Beatles, all of them smoking. Women were beginning to smoke more at the time. This one down in the lower right-hand corner is actually a really brilliant marketing technique. This is Times Square, and there was a billboard on Times Square where that billboard, that was actually real smoke coming out of the billboard. It was a big tourist attraction in New York. That's how prevalent smoking and tobacco use was in this country and how accepted it was, 1964. 2009, this is a picture of the House and the Senate, passed the Tobacco Control Act, very large bipartisan support. So this is one of the few things in the last Congress that both Republicans and Democrats agreed on, and it got passed. And then the picture of the White House, and then the picture of the President signing into law, giving FDA the authorities that I've just talked about. Let's go into the future, though. I've already told you a little bit about some of the authorities FDA has. So let's go 20 years into the future. This is not me speaking here. Make that clear. I'm not speaking for FDA here. I'm pulling this from an article that was in Tobacco Control by Richard Deyton. And the title of this article was, he was doing a visioning feature for the future, looking back and pretending like he was writing in 2032. The title was How Smoking Became History, looking back to 2012. And quoting his article, the FDA, operating under explicit statutory authority to reduce but not eliminate nicotine in any tobacco product, decided in 2013 to reduce nicotine levels in smoke products to non-addictive levels. With the huge US market smoke-free, many other countries simply adopted the FDA rules as their own. So I put this as the last slide because we have this authority now. We can do that. I'm not saying we're doing this, but we have the authority to do it based on the best science. And so now, in addition to the prevention messages, the education, the surveillance, the tax incentives, the clean indoor air, now we have tobacco product regulation as a new arrow in the quiver of tobacco control in this country. You as clinicians play a huge role, not just in your daily encounters with patients and their family, but as authoritative spokespeople for the health of the nation. And so as FDA moves into these areas, we desperately need you, the clinician community, to know what we're doing, give us great feedback when we put out ideas. One thing I didn't talk about here, but everything we do in FDA, we first put out, when there's a regulation we're proposing, we put it out for public comment. And we need to hear from the clinician community. You can bet we hear from the tobacco industry. You can bet we hear from the retail industry. That is what the process is about, and I'm glad we hear from anybody who's interested. But we need to hear from the clinician community about the concepts that FDA proposes and whether it makes sense. And so I end with this visioning in the future of the concept that this guy, Richard Deyton, proposes looking back from 2032, as a possibility. But you see there's many authorities we now have. There's a humongous role for each of you in the clinic every day, but also in helping FDA with the larger public health, population health perspective. So thank you very much for your